What's going on, you guys? Hey, this video I want to talk to you about just a little case report. I had a lot of people say, hey, can you just tell me like what you do every day and what kind of operations and stuff like that. So I have a little operation I'll tell you about. So we had a young male come in and he got a stab wound to the left flank kind of area. And so what we do is do Tls Protocol, which is Advanced Trauma Life Support. So you do the ABCs, the airway, breathing, circulation, actually D, which is disability, which means your neuro exam, and then E, you expose everything and make sure there's no stab wounds anywhere else, or gunshot wounds or other injuries, because sometimes people come in and they say, I got stabbed here, but they don't realize they got stabbed here, over here too. So you do that. He had one stab wound right here, a little bit above the rib cage there, in what we like to call the mid-axillary line. So the axilla, the anterior axillary line is kind of at the armpit in the front. Right in the middle is the mid-axillary line. So it was about there below the nipple, which is significant because in trauma, basically what we say is if it's above the nipple, then it's purely a chest injury, and that's about the 4th or 5th intercostal space for women. If it's between the nipple and the rib cage, it can be both. It can be the chest and the abdomen, so we have to evaluate both of them. He was stable, hemodynamically stable. So what happens in that situation is a lot of times, you know, you talk about, oh, patient comes in, they get stabbed and they get rushed right to the operating room. Well, if they're unstable, if their blood pressure is less than 90, if their heart rate's over 110, 100 or so, then you might start thinking about that. But this guy was pretty stable, and so what I did is actually did a CAT scan. We do a few other maneuvers. We give him some pain medication, we give him some fluids, all that stuff. And if you're concerned that they're bleeding really bad, then you may call for some blood empirically. So I don't know the blood count, right? I don't know if his blood count is super low, but if he's hypotensive, if his blood pressure is less than 90 or less than 100, his heart rate's up, it sounds like he got stabbed. There's only, you know, a couple things that can happen. One of them is bleeding. The other one is like a pneumothorax, and I'll go over that in a different video. So I think he had a pneumothorax actually. So I don't quite remember. With the CAT scan, it looked like the spleen was injured. So that's pretty interesting, right? You think it's the chest because it's the rib cage, but the spleen was injured. So what I ended up doing is take him to the operating room, and I had planned on most likely a chest tube because he got stabbed kind of in the chest area. I was considering that. So I got that ready, and what you do is when you take somebody to the operating room for a trauma, you have to prep them. Okay, well, what we do is we prep the skin, so we try to decrease the bacterial load on the skin because everybody has bacteria, and if you decrease the bacterial load, then you'll get less infections on the inside, right? So what you have to do is prep basically like a t-shirt and then down to almost like shorts, okay? So you prep from there all the way up, all the chest up to the chin, down to the arms like that. And so that way, if you're in the belly and you're like, oh crap, it's in the chest, the problem's in the chest, then you can just go ahead and make the incision in the chest too, and it's all prepped and ready. And then also down to the mid-thighs, because if you need some vein, right, then you can go get this saphenous vein from there and then repair any type of vein, you know, in the abdomen or chest or even neck with the saphenous vein. So that's important to do because you don't want to be re-prepping in the middle of it, right? So then I made a laparotomy incision, which is an incision from the xiphoid down, usually to the pubis, but I did it like a little bit below the belly button. I went in there, there was actually a bunch of blood in there, and now I knew he got stabbed in the spleen from the CAT scan, but there was a lot more blood than I anticipated in there. So I think we did give him a couple units of blood empirically, because I didn't, at that time, you just, you know, you go ahead and say, hey, look, the guy's bleeding. I think his heart rate was maybe up a little bit, so we gave him some blood. You just end up scooping all the blood out. When you go into the laparotomy for trauma, what you do is you pack the 4 quadrants first, okay? Because sometimes you don't know where the injury is. Of course, this one I did, but say he's got a gunshot wound and there's a bunch of holes all over the place, and you open the belly and there's just a bunch of blood that comes out. You don't know which quadrant it is. So you take a bunch of lap pads, or also sponges people call them, and you pack each quadrant, okay? You pack it down, and then you take those out, you see which ones have the most blood on them, and you say, okay, this is the quadrant we need to focus on, okay? Most of the time it's 1, sometimes it's 2 quadrants or even more, but in this situation, I pack the left upper quadrant because I know that's where the blood is coming from. So then once I get it all packed real good and tight, then I can start taking those laps out and see exactly where that bleeding is. Now I have a pretty good idea because of the CAT scan, and that's one of the reasons you get a CAT scan, is because you definitely want to know where the bleeding is, and you want a roadmap before you go in. If you don't have, sometimes you don't have that luxury, but if you do have the luxury, you should take it because it'll make your operation faster and more precise. Then I kind of roll the spleen up, and the spleen is attached to the abdominal wall kind of laterally, so you take down some of those ligaments and you can see where the hole was, and I could see the stab wound in the abdominal wall, but actually the stab wound was in the diaphragm. So that's interesting, right? So that it comes in from the chest, and then there's a hole in the diaphragm. That means it went into the chest cavity as well and could have got the lung. So there was a hole in the diaphragm, not too bad. It was about that big, a couple centimeters maybe, 2-3 centimeters. And then stab wound into the spleen. So there's a couple things you can do with the spleen. You can just take it out if it's really bad, but you want to preserve the spleen if possible. So there's a thing called overwhelming post-splenectomy sepsis, and when patients don't have a spleen, they're susceptible to certain bacteria, and so you want to keep that spleen in as many patients as possible. Okay, they can get super sick if they have post-splenectomy sepsis. So you want to keep that spleen. So it wasn't that bad. It wasn't bleeding terribly at that time. So I have some other options. I can put some hemostatic agent on it. There's some gels. There's some powders. There's some like tissue or sheets of kind of thrombin and clotting factors. You can put some sutures in it, or you can wrap it in, if it's really crushed bad and you're not sure if you're going to save it, you can wrap it in like a vicryl mesh type of thing and kind of try and compress it and stop the bleeding that way. The spleen is really fragile, so it's tough to stop the bleeding, and that mesh thing doesn't really work that great. So in this situation, it wasn't that big of a deal, so I put some of the thrombin powder on it, and I put a couple sutures in it, and it stopped bleeding. So I was okay with that. But now I got to deal with this diaphragm injury. So what I did was just same thing. It wasn't too big. It was a nice clean wound from a knife, and so I just put a couple sutures in there, 2, 3, 4 sutures maybe, something like that. And what I did is interrupted sutures. I'd like to do this interrupted because if you do like a running suture and one of those things comes out and you close the patient already, right? Then the whole thing pops out and you got to go back in. So if maybe one of those sutures comes out and you do an interrupted, so you do one here, you tie it off, you do one there, you tie it off, you do one there, it's tied off. So that's an interrupted. If one comes out, then you have a better chance of that thing staying together and actually healing. After that, I thought all that stuff was good. I washed everything out. You get all that blood out of there, you get all the much fluid as possible out, and then you close the belly. Because he had, that knife went through the chest as well, that means he probably had some air in his chest, and so I put a chest tube in his left chest. And so that was it for that operation. The guy did pretty well, didn't really have any problems, went home not too long, maybe a few days, 3-4 days after, probably 3-4 days after that. So that is my case report for this one. I hope you guys like that. Hey, I got these scrubs from it's called TI scrubs. They're pretty nice. They're like real silky. They're very nice. So if you guys like that, I'll put that in the link below. They were nice enough to send me these scrubs. They don't give me any money or anything like that, but I like them. They're pretty cool. This see little TI thing there. I don't know if you guys can see it. Anyway, hey, thanks for watching these videos. Hey, you guys subscribe, like, share, all that good stuff. I'll see you in the next one. Take care.